Father, we thank you for another day that you've provided for us, and we look forward to enjoying your creation. And we pray that you'll guide us as we meet today, help us to understand the needs that our citizens have, help us to understand and give us the wisdom to make decisions that are pleasing and in the best interest of our citizens. And we ask this in Jesus' name. Amen.
Amen.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay, first business is consideration of a letter in support of an appeal to the Georgia Department of Community Health on approval of an agreement between Piedmont Mountainside Hospital and North Georgia Medical Center. I'll kick this off, I suppose, by saying that in my personal opinion, we don't have any alternative but to appeal this. The consequences for Gilmer County are just too serious if this particular deed goes away. And so, having said that, I'm just simply saying I'm in total support of us appealing this. I'll hand it up to anybody else.
I would say that we have an attorney who specializes in this, actually help write this particular new law. He has a connection in Gilmer County. His sister owns one of the wineries here, and so he helped her plant the vines and so forth, so he has sort of a personal connection here. He agreed to come up earlier in the week for some advice for us, and we met with one development authority and some other interested parties, and we learned that this could turn into a rather expensive process at the hearing if it's contested and so forth and so on. But I would agree, Mr. Chairman, that this is a watershed moment for our community, that there is a lot at stake. And I would agree with your assessment that I don't see that we have a choice in moving forward.
It is I guess one is a good way of putting it. It's critical that we do everything we can to help our citizens in terms of health care and access to it. I am disappointed that our prior letter didn't even warrant a response from those people, as far as I know, directly. So I would suggest if we send the letter, we also copy with a couple other people, including Senator and our Speaker, and I wouldn't even mind seeing the governor see that same request, that letter. I think the more publicity we have and the more communication we have, I think the more impact it has. And I know the process will be probably long and expensive. I don't expect to hear anything early, even this year necessarily. So I think we're in for a long haul, but I think we have to do what we can. I've not seen the draft or anything. Is that something that you can find and have, Travis?
I can provide that. I can provide what we have prepared for the Joint Development Authority. What we had was a legal framework provided by someone at no charge, a team that was available to us. All the ordinances and so forth and all the legalese is there, and then a section was left to put our arguments. And that's what we're working with, and I'll be happy to provide that, or maybe you could adapt it for the county. I think there's plenty of information in this document that all the ordinances, you don't have to look all that up. So.
And I think it's important to say, and it's, I know it's been said publicly before, but I still get some comments and questions about it. I don't have a problem in the world with Piedmont Hospital with their quality of care or anything else. If they wanted to put a facility here, I'd be knocking at their door and telling them thank you. It's just that that's not what the proposal is.
this is about a certificate of need, not any corporate entity.
Exactly.
And it's our intention at the Joint Development Authority to try to open a dialogue with people and see if we can accomplish inpatient care. That would be a fantastic solution.
It would be.
So I would agree with you, State.
Okay, any other comments?
Mr. Chairman, I have a comment, maybe just for the benefit of trying to navigate through the weeds. The certificate of need, is that issued to a healthcare provider, or is it issued to the county itself?
It belongs to the healthcare provider.
It belongs to the healthcare provider.
It is a commodity. They can sell it.
Yeah. Okay, that was my question as to who actually owns the certificate of need, and that is not the county, but whatever healthcare provider, right?
That is correct. Sunlight currently owns it.
And I think, isn't it true, even though they have closed the hospital, they can control that more or less for up to 12 months?
They, the clock starts ticking when the hospital, when the last patient is discharged. They can renew and restart that 12-month clock by having inpatient care, even one patient. So that's kind of the way of the land.
But, and I have, it's my understanding that their intent is to just give it back right away. Have you heard anything about that?
But it can be retrieved, and we verified this with this.
Even if they give it up,
Within 12 months, or if the clock starts over by them exercising their right to provide inpatient care, the clock will start over. And we have verified that.
okay, any more comments? Yes.
Do we have a copy? I saw a copy of the letter of the state's response to the letter of determination approving the Piedmont process. And do we have a copy of that?
I can provide you a copy of it.
Yeah, it seemed to me in there, I just read it personally, that there seemed to be a tie between Sunlink Corporation and the Piedmont leasing of the emergency room, such that Sunlink agreed to do such and such at Piedmont, the state approved Piedmont to do whatever. Was there a leakage in there that shut
The
the
original
hospital down?
letter of determination that was filed December 28th, 2015, was filed by Piedmont alone. On March 21st, 2015, it was refiled jointly. And I think what you're referring to in that letter was a response to that joint filing. I'd have to look at it. We can review it together, but I think the wording you're talking about came out of the fact that it was a joint filing rather than only Piedmont filing.
So the closing of the hospital, Sunlink's disposition of the certificate of need seems to be linked to the approval of Piedmont getting the emergency room, is that right?
It is correct, but Robert Thornton, the CEO of Sunlink, has expressed that they can't keep it open. So I think it's going to happen either way, but it is, and that document appears to be tied to the execution of this deal.
It just doesn't seem that there should be a linkage. It seems to be an issue, either you give Piedmont the EUR approval, period, yes or no, and then Sunlink and the disposition of the certificate of need should be a separate issue. But I was just curious, that's all.
Well, and actually, it's crossed our mind to argue that very point, that those are separate issues. I agree with you.
And they cannot make that a unilateral decision that happens until the State Department of Community Health either approves or not approves. So they have the authority to approve or disapprove at the state level, regardless of what is proposed to them by the healthcare provider. So they actually are in control more so than we sometimes realize.
But didn't the Department of Community Health send a letter back and restating that they approved the Piedmont taking over the ER or leasing the ER, and also that some link has agreed to shut down the hospital.
May 24th, that ruling came out.
Yeah, okay, so it's done. What else can be done?
The appeal can be filed within 30 days of that letter that you're referring to that was issued May 24th. So by our calculation, that deadline is June 23rd. We intend to hand deliver appeals on the 22nd at the latest.
Okay.
1 day of margin. And we're working through the details of all that, but it appears that if they consider the appeal, they'll grant a hearing, and then we get to make our case, and we go through discovery. This is a transaction between two parties that are private, and so we can't do open records requests or anything like that. But part of the discovery process, we will be able to see what are they putting towards that threshold. Their whole point is they're under a $2.878 million threshold, which excludes them from a full certificate of deed review. That's the whole point they're trying to make. But we would like to see the documentation of how their figures are calculated and so forth. And this appeal process, if we get a hearing, includes discovery.
Okay, good. Sounds like a plan.
It's the only, we're in the corner, it's the only plan we have.
Good.
And I'm assuming, I know the cities consider this, I'm assuming they will provide a letter, or has that been determined by the city?
LJ's meeting Monday on it, and I don't know if you want to speak for
We got the application. We will meet the 27th, so we can do it.
that's kind of after the fact, but
We can do it.
since you brought up that letter, I was really disappointed that the Department of Community Health mentioned that there was opposition. There was a little phrase about 6 words that said there was some opposition. They didn't say it was 3 government entities and a development authority and so forth.
On the website, it does. When you look at the review, and it tells all of the oppositions, private parties, and
But that letter you're referring to,
with the letter there.
just a cursory mention, there was some opposition. Come on.
Yes, sir. Mr. Chairman, sometimes when we come in after a meeting starts, we're reluctant to speak, or I guess the same could be said if you're not a public official, but I asked these young ladies to my right, how do they feel about the hospital being closed?
You don't know our
You don't want to know. We're
I think they would like to know.
Certainly.
not just personally. I mean, yes, we've lost our jobs. That's known fact. It's the community. You got to consider 80% of this community are seniors. We don't have the option in medicine to go 30 miles, 40 miles.
Yeah, when you have little old people come into the clinic and say, what am I going to do? I can't travel to Gilmer, I can't travel to Jasper. What am I going to do? And plus, not to mention what it's going to do for our community. No industry's going to come in. I mean, I was born and raised here. I've lived here my whole life. No industry's going to come in. The tax rate's going to go down, or, you know, it's going to go
Property values going to
yeah,
bottom out.
property value is going to bottom out. The school systems, they're not going to look at our school systems. I mean, it's affecting not just us as employees, it's affecting everyone. And personally, I feel that Bob Thornton and Piedmont had a backdoor deal. I think Bob Thornton got his pockets padded a little.
Oh, I agree.
That's
100%.
personally what I think.
A second. Absolutely.
All in favor?
We as ex-employees have been held in the dark. from
Yeah, we
day
don't,
one.
and
Day
we
one.
still don't know. I mean, me and Elaine still have our jobs because we work through the clinic. But, I mean, they won't tell us anything. And June 30th is coming up. I mean, did we come to work on July 1st? We don't know. Nobody's told us anything. We don't know nothing. And we're employees. They just handled it. We're very angry. Very angry. So.
Well, there is a website where you can express your, are you aware of that? SaveGilmerCon.com.
Okay.
You can express your position and sign a petition. And the groundswell of citizen support is going to be very important. So get on Facebook, share it.
We tried to, I mean, we put it out and we're the only three that showed up. I mean, we tried to get everybody to do this.
I think people feel helpless and hopeless. Don't. The community has really come together over this, and we're going to be a force to be reckoned with. That's all there is to it. So,
Well, we appreciate that. I'm thankful for that.
the Joint Development Authority is a very new organization, just formed last fall, 9 or so months ago. One of our basic missions is to retain and expand existing business. So that's first and foremost. Before you attract someone, you look after what you've got. And so we've taken this on. We're going to see it through. We're going to the mountain.
I have another question related to the certificate of need. Has some link, do we know if, Travis, you mentioned that it was a commodity and they actually can sell it.
Yes.
Do we know that Piedmont or whomever has made an offer for that certificate of need, or if some link has offered that certificate of need for sale to other healthcare providers?
Over the past 2 or 3 years, there have been several attempts to sell it. Piedmont was offered the whole package, the nursing home, the medical office building, the hospital, the emergency, everything. They weren't interested. They're just interested in the emergency part of it, and I can understand that actually. But there have been several groups, and still remain at least 3 groups that are interested in buying that certificate of need and continuing operation. And if we didn't have those prospects in the wings, I would see it as a lost cause, but we do. So as long as there's still interest out there, I think it's a reasonable expectation of ACC.
You know, it's not only Bob Thomas, Thornton, who's, lied and cheated from day one. Piedmont has lied and cheated from day one too. They even stated in the paper they offered all of us a job. No, they didn't. Absolutely not.
I find it interesting that no one has ever reached out to the community leaders in this from day one. It's all been done in the dark and so forth and so
In the
on.
snake.
I've never been contacted as a commissioner or a joint development authority chairman.
I should point out here that I have been contacted and met with Bob Thornton and with Greg Hurst from Piedmont. So
I will grant that.
they did reach out to that extent. But I will say that during the meetings, it wasn't what I would deem to be a free flow of information. I think in both cases it was geared more to trying to convince me that their position was what was best for Gilmer County.
They want to shut us down so they can have total control. We're not in competition with them. We've never been in competition with them. But they see us as a threat.
Well, I don't want to squelch discussion, but I would move that we, as the Board of Commissioners, participate in this deal.
I'll second that. Any further discussion?
I think, just a comment before we make it official, but we have to realize that the Department of Community Health is a part of the legislative, the executive branch of the state, which means they ultimately report to the governor. And we have to realize, and everyone has to realize, that the governor is just part of a political process like most of the government and elected officials. So I just want to emphasize that our success in being able to have health care brought back and access to it in our county is ultimately dependent on the governor deciding and agreeing that we need it here and find a way to make it happen. And That's where the buck stops in my mind. And I don't want to forget that that can involve political decisions rather than just our own physical and medical needs, unfortunately. That's fact of life. That's the way the system is set up. That's the way the certificate of need works. And we have to recognize that as we fight for what we think is right. And I think we're doing that by responding and writing letters of concern and request and protest and that. I think we have to do that. I think that's the right thing to do.
Well, we have a motion and a second. All in favor?
Aye.
Okay, so we will go forward with that.
I would like, as I mentioned, to have a copy and have a chance to review that before we sign it, and I'm assuming we'll all three sign
Well,
that
it's-
letter.
I don't think 2 duplicate submissions would be appropriate anyway,
Right.
but it's a pretty good framework, I'd say.
That's good.
Okay. We will then move on to discussion of funding of emergency medical services. Dallas, I think this was.
I asked that we discuss this in the meeting. We, as everyone knows, particularly with the closing of the emergency room primarily and with the closing of the hospital, that puts extra demand on our emergency services, the EMS folks, and that we well recognize that. It does, we've already added some resources for that purpose. We've taken actions on that, and I think the right actions. I wanted to discuss some of the options we might have to go even further than what we've done, just to get everyone's ideas and opinion and feeling on that. One of the things that I looked through was where could we, if possible, eliminate using our EMS folks in some services there and find another way of providing some of those services. And let me give you one example real quick. We talked about this a year or 2 ago, I think it was, of any non-transport calls that we get. We do not receive, as I understand it, any compensation for that. And we are making still, I think, response to calls that result in non-transport conclusion. Maybe they've had a diabetic problem or something and just needed some medicine or something. So I would bring that back up again to talk about a way to help reduce the number of non-transport calls, if that's the proper way to phrase that, where we're going out and we're tying up our resources on non-emergency, if I may say that, calls. I need some discussion on that. I think we talked about earlier of actually setting notification that if it occurred repeatedly that we would end up charging those people for that or something to that effect. I think that's something we can actually do that would help free up our resources and have available for real emergencies. Because now we're spending longer times and probably more calls now since the emergency room and the hospital closed. We're probably getting more calls than ever. And so that's one action that I would think we might take. I think we need to go a little bit further. We talked about the letter to the Department of Community Health. I would particularly like to, as a county government, send some information and letters and requests to not only our state representative and state senator, but to our U.S. senators and our U.S. people to say, we have a problem, we have a crisis, and we need help. I think we need to seek out some financial help from them if we can. I don't know where that'll come from, but I think we need to make an attempt by bringing this to their attention. Letting our senators and representatives know we're struggling with this. We're going to have to spend more money this year than we budgeted, and we know to just ask the cities if there's anything they can do to help us. I know y'all helped us when we had a fire engine, or fire truck, a ladder truck that we purchased years ago. Y'all helped us with that. Maybe there's a way y'all can help us with our ambulance purchase. I'm just asking. I'm willing to beg and ask. I'm not bashful, and I know that I feel like we're doing well serving the whole county completely, and I want to do that. But I think from a capital standpoint, that would be a help to us. I just would ask that we start dialoguing on that. I have no idea where it would go, but that's another aspect. I would like to ask Tony another aspect of what we might do, and that is if we are being, quote, forced to take people to Chattanooga or Atlanta or Marietta, is there any way we can simply shorten all of these trips and go to the nearest available emergency room that has the capability? I don't want to spend a half a day going down to Emory or going down to a 12-star or over to Chattanooga if we can do it on a shorter trip. That's a question I would like to ask. It would save us time and resource. And miles and gas and tires and you name it. We could say, yeah, that's a possibility, and I don't know. I'm looking for a lot of ways where we can do a better job, do a better, more efficient job, where we can find more financial resources. There's one last place, and that is probably $500,000 on a tax. And I'm not advocating that, I'm not recommending that, I'm not ready to vote for that. But if we need $500,000 to support the demand for emergency services, it's got to come from somewhere. So I'm just throwing all these ideas out. I want to hear, particularly from Tony and from you, Charlie and Travis, and from the community, of what might be some very specific action that would help. And I want to do anything we can to improve the situation. It's going to last a long time. We're not going to have this fixed in a month or 2 or 3 or 6 months. It's going to be longer. So those are my ideas, and that's what I wanted to bring out and put on the table. I'd like to have feedback on it and see where people want to go and what we can do. So,
to answer your question about the transport distance of the patients, currently our protocol that's in place follows the insurance guidelines for Medicaid, Medicare, and private insurance as well. Where the automatic protocol is we transport that patient to the closest local facility based on their condition. That's the protocol. We make sure the patient knows that. Now, with that being said, if the patient says, no, I'm not going to that place, you're taking me to St. Joe's in Atlanta or Emory in Atlanta or whatever the case may be, we have no choice but to continue the trip on to that location because that is their choice. Now, we do advise them that if we bypass that facility that is capable of handling their condition, the bill is on them at that point if the insurance company denies it. Because the insurance companies will not pay us if we bypass that facility that could have handled the condition. So in doing that and explaining that to the people that we're transporting, it has really made a difference in those long distance hauls. Mainly now where you're seeing the long distance hauls is the more extreme conditions, the strokes, the heart attacks, the severe trauma, things of that matter that have to go to places like Erlanger, Kennestone, Emory, Grady, whatever the case may be. But as far as the distance of transport on the average patient, we've really cut those trips down by putting that protocol in place and identifying those facilities that handle the specific condition based on where you're at in the county. For example, anything north of the city, most anything except for those major categories can be handled at Fannin Regional right now. This is in the current dynamic we have. True. Anything south of the city is Pickens Piedmont, and anything west goes to Murray. And some stuff on the very far east can go as far as going to northeast Georgia and Gainesville. So we've already identified those areas, and it really is making a difference.
What makes the decision on whether to call for an air ambulance?
The big thing on air ambulance, it's kind of a,
I mean, it looks like the longer distance, if you got to go down to St. Joe, that would be quicker, faster, and better for us if they did it instead of us.
well, the way to look at it as far as the air ambulance, obviously we want to do what's the best thing for the patient. And what plays into that is not only the condition of the patient, but also whenever we call and solicit that response time of the helicopter, based on the time that they give us, 20-minute response time, 10-minute, whatever the case may be, we have to take that into consideration from the time the helicopter lands, how long it's going to take to do patient preparation, which can be 15 or 20 minutes, plus the additional 20 or 30 minutes it's going to take for them to get in the air and get to wherever else. A lot of times, regardless of the condition, we could almost beat the helicopter there anyways, more specifically if we're near 515, if we're near 52 or 282, some more major roadways. Now, if we're out in Tiganetli, far east of the south end of the county that are off the road, that we don't have quick access to the highway, then sometimes the helicopter's our best option because we'd never be onto the facility that we need to go to.
And we can't make that decision until we're on site and evaluate the.
Absolutely. It's a case-by-case basis.
Right.
There's no way to put a set protocol or policy in place that says you will, where it just depends on the condition and the timing.
And generally, where do they come from? They're based.
Right now, the helicopters that serve us come out of Fannin County, which is Life Force out of Chattanooga. There's one in Pickens County, which is Air Life, which they're an independent. They're not attached to a hospital, so to say. They have another Life Force base in Calhoun, which we don't see very much, just because those two helicopters can beat the Calhoun base almost every time.
I have a comment of mine. My mom has been real sick, and the ambulance had to be called up to her house quite often there for a little while. And every time they came in, the EMS drivers would say, "Don't you want to go to Piedmont?" And we would say, "No, take her to LJ. They can handle what's going on with her breathing issues at LJ. If she needs to go further, then so be it."
A lot of times where those type things come from is with the hospital we have here, a lot of times what was expected to be a 24-hour available service, a lot of times whenever we get there, they wouldn't have respiratory, ortho, and things of that matter that we do know that they have all the time. Somewhere like Piedmont or
Respiratory is
closer.
24 hours at North Georgia. It
Well,
used to be.
but we have been diverted on calls like that from North Georgia before.
Okay.
So there's a lot of things that play into that, why those things are said, because we know where the services are available. Because it's really a disservice for the patient if we take that individual to a hospital where we don't know if that service is going to be there, for them to have to get picked up and delayed and transferred to somewhere else that does have that service.
Why didn't they make that known whenever they said, "Don't you want to go to Piedmont?" I mean, they.
I can't speak to that specific incident because.
Well, it was every time, and it was like about 20 times in the amount of like 6 months.
And I've never received any call from anybody on that, or else I would have looked into it the rest of it.
And not only from my personal standpoint, but from ER nurses as well. Patients were asked, "Don't you want to go to Piedmont?" So,
Yeah, that's something that we do not condone in our service. But there again, if we don't know that the situation is happening, then there's not anything I can do about it to research those issues and
Okay.
make sure that that's not going to continue to happen.
fair enough.
It has definitely happened. Actually, the primary was the OR, but the last several weeks before they closed, I was transferred to the ER, and I heard it repeatedly sitting there. Heard the EMT say, "Can't we take you to Piedmont? It'd be a better place to go."
Yeah,
What do you
there
mean,
again,
better place to go?
I've never been made aware of one single issue. And if
That's
y'all
fair
y'all
enough.
do have anything that's more specific, I'll be glad to look into it.
Fair enough.
Can I go back to the emergency room question? And was the agreement that supposedly was proposed currently 24-hour, 7-day-a-week emergency room support that covered with doctors there from Piedmont? Travis, do you know? If they were to come
Proposed
here,
deal?
yeah, the proposed deal,
That is correct.
it is 24-hour and have doctors on call or on site or whatever, but
I mean, that's not in writing, but the conversation is, that's.
okay. Because if we were to have an emergency room that does not have the doctors or the capabilities, then you've got to go somewhere else. I think it's fair, but I would like to make sure we do that.
But until we closed, we had full facilities. Every single department was there 24 hours. Every department. There was never slack department not being there. There was always a doctor there.
Can I go back to the non-transport situations, and are those significant enough and frequency enough that we should address that?
It is still happening, specifically on situations where we show up to the scene and administer medication for a diabetic emergency or some type of a pain situation, whatever the case may be, and we're receiving that patient refusal, or in which we have spent wear and tear on the truck, fuel, personnel costs, plus the cost of medication, whatever service is rendered to that patient. They essentially decide they don't want to go to the hospital at that point and sign a refusal. Therefore, the county is not able to bill for it. If we don't transport, we can't bill. So therefore, the county has paid the cost for that individual call with no ability to recoup the cost.
Well, and I'm more concerned actually about taking those resources out of availability for real emergencies.
Right.
When they're not available, they're already on a call, and that means we got to go get somebody from another county, or we got to delay answering a real emergency. That's my concern.
Well, some of those are real emergencies, but you're able to stabilize.
Absolutely.
Yeah.
And specifically the diabetic situation, that's as severe of an emergency as anything that we respond to, at the time. But once we get there, it's something that we can very easily bring that patient back around to the same thing that the ER hospital would do. But not only does it tie up our resource, as you pointed out, but there's significant cost as well.
Is there a way to, this is crazy, send a doctor or a doctor's assistant or a nurse to make that first contact and know what the situation is? If we know it's not will we know when they call 911? Or what I'm saying is, can we find an alternative rather than send an ambulance and take it out of service, basically?
The way the licensing works for that through the state is an immediate 911 call, and the mechanism that is in place is 911 dispatch of an ambulance. There's no other permitted setup that we could do as the county for situations like that, other than what we are doing.
So the state rules say we got to do it, but they don't necessarily help us financially do it.
No, and it doesn't just fall under the state rules. It's CDC protocol. The Center for Disease Control sets protocols for how things are supposed to be responded to, and 911 and EMS service through a paramedic and EMT is the national standard.
Well, I would say two things. You can't make an accurate assessment every time based on a 911 phone call, first of all. And second of all, you would have to have physicians or physician assistants on call 24/7 to do that, which I believe would end up spending a lot more to make those resources available on call.
The question I ask, and the reason I raise that is there are supposedly funds available to help with that, and I'm going to go through some of these things to see if that's an alternative. If it would be practical to have a doctor make that house call, and it was not costing us, would that work or not? I mean, you're saying protocols don't really allow that.
Well, the main thing is too, is talking about a doctor. I guess my question would be how the dynamic would work to have a doctor or doctors on call or available from an immediate 911 call, and how they're going to dispatch and respond. I'm not aware of that type of setup.
No, I don't know that we've ever done that. We know whether to send an ambulance or a fire truck or a policeman, but maybe sending a doctor would be another.
I can't imagine though that sending a doctor would be a money saving.
I'm not talking about my money. I'm not talking about my money.
Well, it is your money.
Well, it is. It's going somewhere
Well,
else.
and I would say you put 911 dispatch in a very tough position making a judgment call on what resource to send in that situation, you make the wrong call.
I understand, and that may be the case.
I don't think that's a viable solution for it.
We may, that's why I want a dialogue on this, and then I'm not being, I don't want to.
Yeah, the doctors wouldn't be able to carry in an EKG machine. They wouldn't be able to carry in all the drugs necessary if someone needed some medication. They wouldn't be able to carry in a lot of the resources that the EMS can take to the scene. And plus, a doctor on call 24 hours a day, you're gonna have to pay them for being on call. They're not gonna take call for nothing.
The EMS is gonna go in, they're trained. They're gonna go in, they're gonna evaluate, they're gonna do what needs to be done. You send the doctor, now you've lost another 20 minutes, because he's gonna have to call EMS then. So now you've doubled your time, you've lost that person.
The only, I hear that and I appreciate that, and the only thing I'm saying is after we make the third call to this same address, to this same person for this same 911 call, I'm not sure we can't make a reasonable call on whether that's necessary or not.
You can't discriminate against that.
As
You
they
cannot.
dial 911, we have no choice but to respond.
That's right.
An emergency unit, regardless of what we think or know it is, even from the onset of dispatch, we have to respond the same.
That's like a patient coming into the clinic. We know what they're there for, we know what they want, but we can't discriminate them and say, no, you can't see the doctor just because you want some pain pills. I mean, we can't tell them that they can't come in, so that's just like saying to the EMS, no, don't go see them because they're in a diabetic coma again, because they won't take care of themselves, they won't manage their diabetes. You can't do that.
But this fourth call they've gone out on doesn't end up being diabetes. And you say, well, it's diabetes, yeah, we'll send somebody else. Just because 4 calls are diabetic doesn't mean the 5th call is going to be.
A heart attack.
And that's why I think the mechanism is more so, the billing type response, where we're trying to recoup that cost, but it doesn't change how we respond. Regardless of how they call, we're still going to respond the same. And I think we have to, because that's the only way we'll ever be sure that we're providing the best care to that patient, regardless of the situation.
And I'm happy with hearing that and confirming that. That's okay. Let me just switch to the financial side very quickly because I don't want to spend a lot more time on this. But we'll look at it. I have no numbers that says how much more the county will be having to fund EMS because of the hospital closure and emergency room closure. There's more cost. I mean, we know we bought 2 more ambulances. We know we hired some number of people. I don't even know how many. So we know there's more cost. I'm going to pick a number unless somebody can prove me wrong or improve the accuracy. I'm going to pick $500,000. By the time we talk about all the costs for an ambulance over the 5 years, all the maintenance, all the fuel, all that, plus all the extra EMTs and their costs associated with their benefits, et cetera, whatever.
So then when you say over 5 years, are you saying you're picking a $500,000 cost for over 5 years?
The total, yes.
Okay, so
Yeah.
Let's talk up the name.
I don't know that would be a number to start with. I have no accurate number at all. But there's more. All I want to make is a point. There is a 6-figure number that we're dealing with from a county level. So that's what I'm saying. I'm going to read some numbers because I think this is significant to us. The budget for the state was $4.3 billion for health care. I don't know how much a billion, I don't know how much of that we get. The state budget is $40.9 billion available to them every year, which is state funding and federal funding and other funds. There's some money there. We need to find out which of it is there. The federal funds, what I read, is designated $6.4 billion to the state for Medicaid and peach care. I'll assume that some of this would be Medicaid or Medicare related things, I don't know. $1.7 billion for temporary assistance for needy families. That's a specific program, and that may fall into where we support, provide services through the EMS folks. There is a reserve fund that the state has. It's currently at $863 million. This is a rainy day fund for things that showed up as an emergency and we don't have a budgeted, and that's a fund that can be used to maintain services and pay for expenses that weren't covered. And I would say we're not covered for handling a county without a hospital right now. I'm just saying that there's a lot of other departments, there's a lot of other appropriations. There's a healthcare access and improvement appropriation that's gone through the State House and been approved, House Bill 76. There's an indigent care trust fund that is out there to support rural and healthcare providers. And I consider our EMS folks a healthcare provider, and even though it's a government, it's not a private one, but we do provide healthcare, let's face it, from the EMS. There are funds out there that I think would apply if we go seek them and try to work with that. I'm not willing to not try to do that and just raise taxes or raise our budget or cut other services to handle the increased demand for EMS services. So I'm just raising that as something I would I guess informally like to ask you, Charlie, to write some letters to our congressmen and senators and explain our situation and see what they would recommend and what they might do for us, whether it's Ralston or whether it's our senators in Washington, D.C. or wherever. Whatever we can do, I think we ought to do it. I think we ought to I'd like to send that letter to the council, city councils, and ask if there's anything they can do. And I'm just begging.
I kind of jump in here. As all cities, we've for a very long time, the county and the cities have just been kind of at each other. And it's my opinion, my belief that for the last year and a half or so that we've kind of come together.
I agree with that.
And we have a sense of cooperation now. The cities are aware of the situation. I don't want us to be so aggressive with asking for help from the cities that we endanger
I agree with
the cooperation that we have overall.
I agree with that 100%, and I don't mean to be that way. We have a common crisis to work on, and that's our job.
I think it's
Just
also
to work
worth
on.
noting that in 2012, the lost sales tax structure divide was changed, and the city of LJ went from 17% to 16%, the city of East LJ went from 10 to 9. So there has been a transfer of some recently that, from the city's perspective, I think they can make the argument that that is helping to fund this situation.
It wasn't done to help this situation. I agree with that was done, but it was not done to help
Specifically,
this crisis.
but I would also like to echo what Charlie said. The spirit of communication, cooperation in the community is unprecedented in recent times, and I don't want to do anything that drives a wedge.
I don't either. However, we have a city without a hospital, and that bothers me. We need to do anything and everything we can to change that situation. That's all I'm asking. That's it. That's all I'm saying.
Obviously, we're not following Robert's rules of order according to the agenda, but as a taxpayer in the city of LJ and as a taxpayer in the county of Gilmer, if you're going to raise taxes, no sense in spreading it around. You might as well. You're in extraordinary times here. We've heard a lot of things thrown out here. Does there need to be a subcommittee to come together to, focus on what needs to be done? But as a taxpayer in the city of LJ, I'm more than willing to do my share in extraordinary times. Just do it through your organization as the lead agency and the lead government in the county of Gilmer. That's,
I would agree with that.
To ask the city of East LJ and the city of LJ to share the burden, that's one thing, but the bottom line is EMS is responsible through our county government. And we're in extraordinary times. We have to do extraordinary things. And Travis certainly with taking kind of the lead on this thing with the hospital has done that on behalf of the city, on behalf of the county, and on behalf of the JDA. And I echo what you said, Charlie. For the first time ever, our three municipalities are working together. Let's keep it going. This is extraordinary.
And I think the value of that transcends any individual crisis that we have. Just slap it on the tax bill. Just don't put it on the city.
I've said my piece.
David?
And this is just by way of what I've gathered through the years, but, and I believe Dallas's concern is addressed to EMS services, which is the ambulance side.
Yes.
And I believe you've thrown the number out like it could potentially cost the county anywhere from $400,000 to $500,000. It's your belief, as I understand it, is that correct?
Well, I know we've got $140,000 for a couple ambulances.
But in that regard,
I know we've got salary increases for existing EMTs. We've got new EMTs. I know we have directly to our county general fund and capital fund, we have committed, and I threw out the $500,000 number because I think over the time frame of what we're talking about, to pay for the ambulances and the salaries and benefits, I think that's the magnitude of EMS resource increase that we're dealing with.
but what I would counter with is that the environment you're in, unfortunately, the closure of the hospital has increased the calls on the EMS side. But it's really the reason that the EMS side, and it's a profitable department, as I've always understood, and the profit from that department was diverted into the general fund and not reinvested back into the department over the years. And that's a management decision, and unfortunately, that management decision in years past has come to fruition. And this Bill Ford commissioner had to invest in purchase new ambulances. In fact, if that fleet had been maintained over the years, I don't think the issues that are being presented by what you're suggesting would be existing at this point in time. Because if Tony and them had ambulances renewed over the years, you wouldn't be seeing this expenditure. And if the profits from that particular operation had been diverted back into the general fund and been reinvested back into EMS services, nor would you have an increase in that expenditure. So I don't necessarily, I think characterizing it as a huge problem, because I think, and I would defer to Tony, but I think that with most of those ambulance responses, it is a profitable venture in some respects, and we should never characterize it as a venture because the county's not into a profit-making stage, but it's a break even at the minimum, is it not?
on the EMS, although we are a combined effort department, if you look at the EMS services specifically, it pretty well breaks even by the time we bill and retrieve that the money off of that. Now, if you're looking at the department as a whole, which we're combined into one big department, as far as the fire and rescue portion of it, no, it does not break even. But as far as the EMS portion of it, only the ambulance transporting patients and providing that medical care, we substantially have increased our revenue even over the last few months from these type of calls.
In years past, that increase was diverted from the department and was actually used to fund other aspects, whereas you didn't have your fleet maintained, and that's where this board is suffering from that management decision from years past. You're
And
playing
it's
catch-up.
compounded because that's not just the situation with EMS. We're playing catch up in the road department, planning and zoning, parks and rec, you name it, it's across the board. So it's a bad situation, and we are playing catch up. One thing that I would like to discuss just a little bit, because since you brought it up, is the fact that we have hired more EMTs, and we've given raises to the EMTs because we found that we were paying so low that we couldn't attract and hire additional people. We've discussed this before, and it was my understanding that you were on board with it. I wonder now, because I know on 2 separate occasions you've asked for the breakout of how much extra we're paying and so forth. I just want to make sure that if you're not on board with it, I need to know that.
I will be on board, but I do not like making decisions without data and without a dollar figure that I know I'm making a decision about. That's the only point. It's a matter of, I have not objected to adding EMTs. I've not objected to adding ambulances. I voted for that. I'm not objecting to the support and providing of services to our county at all. The one question I have is, and it's a reasonable question that I think the citizens need to have an answer to, is how much will it cost us and where's that money coming from? That's all I want to have answered. That's just my reasonable question. That I have no intention of not providing services that are needed. That's not my point.
I don't think, Dallas, I don't think we will ever, no matter what the situation is, be able to come up with a defined, for sure dollar amount because of the nature of the business. I mean, we're trying to budget and come up with a hard number based on how many times somebody calls 911 in a year, or when they get sick or injured, or how many of those calls there is. There's no way for us to fully 100% plan to know what the volume is going to be or what the demand is going to be. We just have, a lot of times it ends up being a best estimate based on forecasting.
Sure it is, and I don't know what that estimate is. I agree with you.
Well, I agree with you.
I agree with you.
There's 2 things that I believe everybody here knows. The first is that with the possibility of an ER going away, which, whatever the future holds, that has happened to this point, that it is going to cost Gilmer County more money. The first thing is that we have to have a plan to compensate some way. And the second thing is that it's going to cost us more money, and we all know that. But we've got to look at the situation. We've got to understand that the ER is gone, and that we're going to have to ramp up services, which may mean additional ambulances, additional people. We can anticipate that any particular call is going to take longer than it used to. That ambulance is going to be out of service a little longer than it would have been a couple of years ago. And the only reasonable response I see to that is more ambulances and more trained people. If there's an alternative, and I'm open to it, but I'm not seeing it. And I don't think we have a choice.
The silver lining here is, you mentioned other departments that we're playing catch-up on too, and you mentioned road department. If we invest in equipment and personnel there, we're providing a much-needed service to our community, granted. But it's not a revenue-producing activity. In this case, it is. When we're investing in more personnel in EMS and more apparatus in the EMS department, when they become active to meet the increased demand that we all agree is in place, the revenue rises with it. So it's not a situation where we're completely having to eat the cost. The revenue is rising with the expense.
I agree with that.
And when you're at basically a break roughly, I don't think moving forward we're going to have the budget crisis that we might think because of that. Cash flow is going to take care of itself to some extent.
I want to believe it.
I do too.
I want to believe it.
Well,
And by the way,
we're going to believe it until it shows otherwise.
I want to make a public comment to Tony. I know how hard Tony has worked. I know that personally and individually, directly, of what he has tried to do to weather this crisis, and things he's doing even beyond what has been announced and what has been public and what he's done. I want to compliment Tony to say you have done everything that I think the citizens should expect to try and weather this and bring things to us. And I want to compliment you for that publicly, because you don't get that thanks every day. We do have a crisis, and you, first of all, you recognize it, and secondly, you responded to it as best you can with everything you've got, and I know some things that you're still working on to try and help. So I want to make that as a public statement to not anybody, whether it's the hospital people or anybody, if there is anything that is not working right and the protocols aren't right, then Tony needs to know that, because he acts on them, and he can take that and work on it. And I want to offer that to the citizens. We need that input. Tony needs that input, and as a commissioner, we need that input. So I want to just add that as a closing comment of mine.
The other issue that you raised, Alice, was the charge for the non-transport. That issue, we did take that up a little over a year ago, and it was dropped. I believe that there are several models in surrounding North Georgia region that have merit. I do. I don't think on a one-time occurrence we necessarily should make the charge. But if we can identify chronic misuse or abuse of our system, I thought it was appropriate to charge for it then, and I still think that. So I'm willing to take that back up.
I have a question, because I don't know much about the EMS, how you bill and everything, but when you go out and you administer medicines and everything, can the medications not be billed to their insurance? I mean, I know the actual call cannot, but I mean, can you not bill the?
The way it is the insurance will not approve any cost to us unless we accrue mileage on the ambulance. Now, talking about like on the first time, I think if we can do this, consideration needs to be made to where we can just simply bill for the medication, regardless of how many times we come here. Bill, yeah, to cover the costs. Now, the recurring abuse of service where we don't really administer medication, we're just being called out there constantly. I think that's where we need to look into the, the warning and then whatever the process may be towards more of a use of service fee then, but we need to be able to recoup costs on medication every time.
I would agree with that. And you'd have some discretion in identifying the use cases.
Absolutely.
I think that's appropriate. I thought so when we talked about it before.
Right.
Well, we can add that to the future agenda. We'll take it back up. Now, one thing that I would say, though, if we're going to take this back up, I know that the previous commissions have discussed it, and I know that in at least one, and I think in two different occasions, over the past year and a half, this commission has discussed it. If we're going to bring it back up again, my only request is let's make a decision one way or the other and be done with it. I don't want to just keep bringing it up.
I'm willing to do that too, Charlie. I agree.
All right, any other comments?
Mr. Chairman, there's one other thing, and I wanted to, I'm sure you all have thought of every avenue to try to get to the negotiating table with Piedmont and Sunway. You have one power that I don't know if you have thought about that is available to you. That is the power of eminent domain. That hospital was a public hospital at one time, and it was converted from a public hospital to a private hospital. My wife happened to be there when that occurred. And the Joint Development Authority, I'm sure is doing everything that it can, but don't forget about that power. That power is available to you.
I abhor.
I know that it is a dirty word, but what you have heard here is the community is in a state of crisis. And, you know, everybody is in agreement that that is a critical thing. And I'm not saying use it.
Here's the problem that I see with it in this particular case, totally over and above the fact that I'm opposed to it. It's my understanding that when you use eminent domain, basically what you're saying is the public has a greater need for this property than the person does. And, you know, since apparently you wouldn't sell it to us, we're going to take it from you, we'll give you something in return. But there is that aspect that you have to demonstrate that there is a greater public need for it. The thing that complicates that here is we would have to demonstrate that there is an opportunity to put a hospital there, either by the county or somebody else. And the complicating factor to that is that certificate of need. Because nobody can do anything without a certificate of need in terms of hospital. It exists. Sunlink owns it. And if we go in and say, okay, well, we have a greater public need, we're going to build our own hospital, the first thing they're going to say, where's your certificate of need? In this particular situation, I don't see that being.
Well, I'm not suggesting that you build another hospital.
Well,
I'm suggesting.
I'm not going to take land to build Walmart.
I just want to, you know, I want to be sure that we have explored every avenue that we can to try to become a player in the negotiations. Whoever it might be Piedmont and Sunlink today, and next week, who knows, it might be someone else. But Travis mentioned that there are 3 prospects that are waiting in the wings to see what happens. I don't know if Sunlink is even of the mind to want to negotiate with those 3 prospects.
It's been my experience that they're only wanting to do Piedmont.
That is the impression that I get, is that they've already made their choice, and the power of eminent domain may be an avenue that you can use to have other players to be included. That's just a suggestion that you explore that avenue.
Do you want me to get you a little bit more outraged? Northside offered to get OJ. They were going to keep everything open. They were going to keep the hospital open, all the services running, and everything. They wanted North Georgia Medical Center.
I'm not sure that's an area we want to get into.
But I just want you to know, that's why we say that about Bob Ford.
Yeah.
So.
In terms of the eminent domain, I hear what you're saying. I do recognize that that's a tool available to us. The nuclear weapons are a tool that are available to us. But I don't want them to use them.
I'm not saying that you have.
I know what you're saying. Evaluate the possibility.
Just have all of those options available to you, and make it known that you're willing, that you are looking at those options.
Point well taken.
Any other comments?
I have a personal question for everybody in the room. In the last 5 years, you can raise your hand or not, did you or did you not use North Georgia for your health care needs? Did you, anyway? Preventative? Emergency?
I hadn't been to the doctor, so.
All right, that's fair enough, fair enough.
I certainly have.
Just a curious question.
Okay, anything else?
So let's speak first. I make the move that we go ahead and have citizens wishing to speak.
I thought we were just getting it, I'm sorry. Okay, citizens wishing to speak. Anybody that wants to speak about anything else? We actually never even approved the agenda, so.
I make a motion that we
I'll second that.
Okay, is anybody, any comments anybody wants about anything?
As a citizen,
All right.
I believe we've identified a vulnerability in our county ordinances and practices and precedents. I have prepared a case study that tests that vulnerability, and I'd like you all three to consider it, and I will talk about it at our next meeting, and I'll leave it at that. It's a written form, and you can take it at your leisure. I'm purposely trying to export what I see as a vulnerability in this county, this case study. My challenge to you is to, how would you stop me from implementing this business plan using existing ordinances and precedents? It's not going to work on this.
Oh, yeah.
I promise you that won't work.
Anybody else, any comments at all? Would anybody like to make a motion to adjourn?
Executive session.
I know that that's on there for every particular occasion, but did we really have anything?
Let's have a discussion.
Okay, then we do have something for executive session, so
I'll make a motion, we enter executive session.
I'll second that. All in favor? Aye.
Thanks, everyone, for participating.
They'll give you a meeting. That's just the first.
Either way, it's but you don't have anything that says, well, we fixed it, but we need to keep moving.
Well, we know the order.
I didn't see what you think.
No, that's okay.
If you have insurance, you would be responsible for the bill.
No, I think it's
So you don't have to be further transported.
That's right. Now, the hospital pays, what that's going to be, what they call us, they would pay us, they're still us. So in the grand scheme of things, you end up.
Well, I guess the real thing is, I'm not sure. At what point did transport fall out of county?
Whenever somebody just does not pay.
So that'd be.
Basically, think about it.
Thank you.
Not to call on
One on the. I'm more flexible. Rear. But other than that.
We will. But that was the question. That was the question.
Same.
The immediate
It looked like a case study.